So, what fungal pathogen mimics TB, literally laughs in the face of echidocandins, and traps medical students on board exams year after year? Well, if you're gearing up for your boards or clinical rotations, you absolutely need to know the answer. Welcome to our latest explainer. Today, we're tackling a primary fungal pathogen that is notoriously tricky, highly lethal if missed, and just completely packed with high-yield exam traps.
Consider this your clinical and diagnostic essentials of blastomycosis, the Trap Dodger Boot Camp. We're going to take you through the exact morphological features, the clinical presentations, and the pharmacology pitfalls that test writers absolutely love to use to trip you up. We're going to make this fast, incredibly focused, and totally unforgettable.
All right, let's take a quick look at our battle plan. We'll meet the Great Pretender, check out its virulence focus, map its epidemiology and mimics, navigate the diagnostic danger zones, load up our treatment weapons, and then run a final trap gauntlet.
Section 1. Meet the Great Pretender.
Okay, so Blastomyces is a thermally dimorphic fungus, right? It's a mold in the cold soil and a yeast in the heat of human tissue. But to actually beat these exam questions, you need to know exactly what it looks like under the microscope. The absolute must-know, golden ticket buzzword phrase here is broad-based budding yeast. We're talking about a pretty large yeast cell, usually 4 to 29 micrometers, featuring a doubly refractile cell wall. But seriously, the real dead giveaway? That broad attachment base right where the single bud forms. If you're reading a path report and see doubly refractile cell wall or broad-based bud, boom, you are looking at Blastomyces. Lock that into your memory right now.
Now, test writers love to see if you can actually distinguish these fungi visually. Blastomyces has that distinct broad-based bud we just talked about, but beware the mimics. If a vignette mentions a narrow-based bud, they're pointing you straight toward Cryptococcus. If they drop the word pseudohyphae, they want you to pick Candida. Literally, just the difference between the words broad and narrow is going to make or break that question for you.
Section 2. Virulence Focus.
We know what it looks like, but how does this fungus actually survive and cause such massive issues in the body? It all comes down to its chemical weaponry. The absolute heavy hitter in the Blastomyces arsenal is a 120 kilodalton cell surface protein called BAD1, or Blastomyces adhesin 1. This protein is wild. It gets heavily upregulated when the fungus converts to its 37-degree yeast phase inside the host. BAD1 acts like a grappling hook to facilitate adhesion to the lung epithelium, and then it goes to work actively suppressing your immune system. It binds to receptors on immune cells, downregulates TNF-alpha in macrophages, and totally impairs CD4 plus T cell activation. In fact, if you experimentally delete BAD1, the fungus becomes completely avirulent. It's essentially the ultimate stealth cloak.
And that brings us to a massive trap warning. Because of incredible virulence factors like BAD1, Blastomyces is a primary fungal pathogen. Do not, under any circumstances, fall into the trap of assuming that only patients with AIDS or organ transplants get this. It actively infects young, totally healthy, immunocompetent patients. Unlike opportunistic bugs, Blastomyces does not wait around for a weakened host.
Section 3. Epidemiology and clinical mimics.
So where does this pathogen actually hide out, and how does it present? Geography is usually your first big clue in a clinical vignette. You're looking at the Mississippi and Ohio River basins, the Great Lakes area, and the St. Lawrence River. If a question mentions a patient doing construction, excavation, or maybe canoeing in these regions, your antenna should immediately go up. But you want the ultimate high-yield exam giveaway? Beaver dams. I'm serious. If you get a vignette about a healthy guy who was hiking near beaver dams and now has a cough, slam the button for Blastomycosis.
It's also super important to realize that not all strains behave the exact same way. In North America, we're mostly dealing with two species. B. dermatitidis is found all over the traditional range and has a really high rate of dissemination. We're talking up to 48% of cases. On the flip side, B. gilchristii is mostly restricted to formerly glaciated areas, and it tends to remain localized right in the lung in over 90% of cases.
So when it does disseminate, where is it going? The skin is by far the most common site, often showing up as varicose lesions or ulcers that look incredibly similar to skin cancer or pyoderma gangrenosum. Bone is the second most common, causing osteomyelitis. But here is the trap. The CNS is involved in less than 10% of cases and usually only in severe AIDS patients. Do not let test writers trick you into thinking the meninges are the primary dissemination site. That's coccidioides, not Blastomyces.
Section 4. Diagnostic Danger Zones.
Okay, you suspect the patient has blastomycosis, but getting the definitive diagnosis is where some of the most dangerous exam traps actually lie. Fungal culture is the definitive gold standard, sure, but it takes 5 to 28 days. You can't always wait that long. So you might reach for the urine or serum antigen test. It's fast, but here's the massive catch. It cross-reacts 96% of the time with histoplasma. Since histoplasma lives in the exact same river basins, an antigen test alone won't tell them apart. A much better option is the B81 antibody test we talked about earlier. It's 87% sensitive and highly specific.
But whatever you do, avoid the absolute trap of the traditional complement fixation, or CF serology test. Its sensitivity is an abysmal 9%. It's basically useless. If a multiple-choice question offers traditional CF serology as the best next step, cross it out immediately. Don't even think about it.
Section 5. Treatment weapons.
Once you've correctly identified it, how do you actually cure the patient and secure your points? First rule, every single patient with blastomycosis must be treated. There is zero watch and wait here because the risk of fatal dissemination is just too high. For severe cases, ARDS or CNS involvement, you follow a strict two-step pathway. Step 1 is induction with lipid amphotericin B. You hit them hard for 7 to 14 days, pushing that to 4 to 6 weeks if the CNS is involved. Step 2 is maintenance, stepping down to oral itraconazole for a total duration of 6 to 12 months.
Now here is an absolute favorite trick of exam writers. Do you use echinocandins, like caspofungin or micafungin, for blastomycosis? Never. It is strictly contraindicated. Why? Because echinocandins target beta-1,3-glucan in the fungal cell wall, but blastomyces yeast has minimal beta-glucan in its wall, which gives it innate natural resistance to this entire class of drugs. Picking an echinocandin on an exam is a guaranteed wrong answer.
And the traps don't stop there. Let's look at the azole danger zones. First off, itraconazole capsules require a highly acidic environment to absorb properly, so absolutely no PPIs, no H2 blockers, and no antacids. Second, don't just pick fluconazole because it's a common antifungal. It has poor activity against blastomycosis. And finally, the biggest trap of all, pregnancy. All azoles are teratogenic. If you have a pregnant patient with blastomycosis, lipid amphotericin B is literally your only option.
Section 6. Final Exam Trap Gauntlet.
All right, we are in the home stretch here. Before we synthesize our buzzwords, consider this terrifying statistic: 40 to 89%. That is the mortality rate if blastomycosis is allowed to progress to ARDS. It complicates up to 15% of cases and is highly fatal. This is exactly why early detection, bypassing the mimics, and rapid, accurate treatment is so crucial. The stakes here are incredibly high.
Okay, let's run the final gauntlet. Visual ID, broad-based budding yeast with a doubly refractile wall. Geography, Mississippi, Ohio valleys, Great Lakes, and beaver dams. Pathogen profile, primary pathogen, it actively infects healthy, immunocompetent people. Clinical presentation, the great pretender, mimicking TB, pneumonia, and malignancies. And the ultimate drug trap, never ever use echinocandins. Watch out for that itraconazole PPI interaction and use amphotericin B in pregnancy.
So you've seen the traps, you know the exact morphology, and you know your pharmacology weapons. The only question left is, are you ready to spot the great pretender the second it shows up in a clinical vignette? Review these takeaways, lock in those high-yield buzzwords, and go crush those board exams. Thanks so much for joining me on this explainer, and keep learning.